But I'm very excited to introduce our panel today. First, we have Dr. Michael McCormick, who is the Medical Director of Care and Treatment Center's Healthcare Professionals Program, where he leads their assessment program and provides daily care to inpatient healthcare professional patients. He is also the physician in charge of Caren's opioid treatment program and oversees medication-assisted treatment decisions and induction of treatment for this population. Dr. McCormick is also the recipient of the Next Generation Award for Fellows in Addiction Medicine, concentrating on adolescents. Next, we have Kathy Moore, who is the clinical supervisor for the Healthcare Professionals Program at Caren. Kathy is responsible for the management and coordination of treatment for all healthcare professional patients. Her area of focus has been helping healthcare patients gain insight around their addiction, trauma-related and behavioral issues. And Kathy has provider status in cognitive processing therapy, a trauma-focused psychotherapy which demonstrates efficacy and provides empirical evidence when treating post-traumatic stress syndrome. And finally, we welcome Steve Wolt, who is the CEO and founder of Veritas. After spending several years in corporate America trying to manage his own recovery journey, Steve grew from his experience to create Veritas, which is a substance use and trauma program exclusively for licensed medical professionals. And the goal of Veritas is to bring together industry leaders in clinical treatment, executive coaching, and healthcare coordination to create a virtual outpatient concierge level treatment program designed to meet the needs of recovering individuals in the medical community. Veritas is also an offshoot of Freedom Institute, which is a New York City-based substance use disorder treatment center that's been around since 1976. So thank you all for joining us. And I want to start off with a question to Kathy and Dr. Moore. You know, the past year has been traumatic for the world, and certainly has been an experience for those people on the front lines and those healthcare professionals. So I want to ask both of you to give your thoughts on what are some of the biggest challenges that they've been facing, and how are those taking a toll on their physical, mental, and spiritual health.
Great, thank you, Mark. Thank you for that. That's a great question. And what we've seen is it's almost been in two phases, really. The initial phase was March, April, May, when the fears had led to increased anxiety and depression and early isolation of a lot of our patients. And it really wreaked a lot of havoc with them. The other early part that we saw, which was interesting, was a lot of stressors around finances as well, as practices had been shut down and people didn't know what their income was. They were laying off employees, and that led to a whole onslaught of stress as well. So overall, what we see in that period of time was anxiety and depression on the rise, fear kind of driving this force behind the COVID, fear of a lot of different things, and then increased psychological problems that leads to, but also increased substance use. So we did see it in different categories. We had some patients who had been sober for a period of time, and this triggered not only that, but sometimes a trauma response with them. And then we also had people who maybe had an underlying smoldering substance use issue, and then all of a sudden it came to the forefront. So that's really what we saw early on. And then as the summer progressed, I would like to say that our numbers of patients that we've treated has gone, you know, it went up pretty quickly. We usually have a pretty good census. And since this has all occurred, though, it's really been extremely busy here. And we know that it's going to be busy for a while to come. So as the summer progressed, kept pretty busy as well with patients coming in, and it was still those same things: increased anxiety, increased depression, fear. More mid to late summer, we were seeing a lot of patients that had not done well with the virtual aspect of their recovery. You know, they just didn't seem to do well with the Zooms and losing that personal touch and contact. and had kind of drifted away from their sobriety. That's what we saw. Now we know that, you know, opposite of that, we know that a lot of people did very well with the Zoom world and were able to get on meetings from, you know, the Philadelphia area to a California meeting with a New Jersey speaker. And those people seem to adapt well and stay, you know, in close contact with their network. And then as the fall started, really it kind of exploded again and has been busy ever since. And those things that were previously mentioned are really what we're seeing. It's an increased amount of anxiety about everything, about the future, about COVID itself, bringing it home to family members, getting it themselves, uncertainty with that it continued. The depression had definitely shown itself, and the trauma symptoms, which I'm sure Kathy will talk about, really came to the forefront. And it's really been a big issue for us. We've also had, you know, we're typically alcohol number one, and, you know, benzodiazepines, we always say, are, pardon me, are 1A, followed by opiates at our place. But we've seen some outliers. So we have seen some, you know, ketamine use. We've seen, which is dissociative, of course, right? Trying to get out of reality and get away from my life. And we've seen some inhalant use as well, you know, a fair amount of nitrous, which, as we all know with the healthcare professionals, whether you're a dentist or an oral surgeon or an anesthesiologist, you're around those gases. But they, you know, when you think about it, those two substances and their families work in the same ways, because you're just trying to remove yourself from your perceived reality and your life and your stresses and just kind of move out of there. And so we have seen an uptick definitely in those substances, which has been, you know, interesting to us, but not unexpected. But I think that, you know, the part of the question is so good, is the physical manifestations. Absolutely. Gym shut down. I'm not walking. I'm not running. I'm not doing the self-care that I need to. The mental has just been, that stress has been unbelievable. And then the spiritual, drifting away from what has worked for someone for 6 months or 6 years. You know, we've certainly had some patients who have had long-term sobriety who have unfortunately relapsed and ended up back with us. And the other thing too, I would say, is that there is more, we noticed a little more awareness from some family members. So maybe husband, wife, mom, dad, whomever it is functioning and going to work, and their substance use is there. Now all of a sudden everyone's kind of at home and having dinners together and around, and it's become more aware in families. And so we've noticed that as well. And I'll pass to you, Kathy.
Yes, thank you, Dr. McCormick. So from a mental, emotional, physical, spiritual perspective, you know, the healthcare workers, like you said, for the last year have been taking on such struggles and challenges. And I think that's a good way to put it, the phase 1, phase 2, you know, like what we've seen and what we believe, like the exhaustion. Dr. McCormick mentioned everything. The trauma is a huge piece to this, which we work on here and see, you know, PTSD, people actually, these warriors on the front lines are seeing people, you know, die daily. They're isolated. They don't have, they're away from their loved ones, you know, and then the addiction issues start, and then they come to us. So we kind of tease that out. But I mean, we believe that we haven't even seen, this is like the tip of the iceberg, because these people are on the front lines. They stand up until they fall down. They're at their post. They're warriors. And now I think we're going to start seeing that other phase more come in, because, you know, they don't give up, and it's taken a toll on them from that perspective. So yeah, so I think we've only begun to see what's going to happen here.
Agreed.
Yeah. Thank
Agreed.
you.
And there was one other thing, and then I'll pass to you, Mark. We'll just give you an example. We had a patient early on in that first phase who took care of COVID all day. A wonderful lady who did so well with us, but took care of it on a, you know, from the normal work day, and then would come home. And because a lot, you know, we saw that, and maybe some people on this call as well, that obsessive nature of COVID early on, we're watching then the news as soon as we get home. And so she would get into that cycle of working all day with it, watching the news, which would heighten her anxiety and her stress and her symptoms. And then she'd have to kind of come down from that. And so she would drink until, you know, late at night, and then do it the next morning and do it over and over again. That's just one example of really what we saw.
It's like witness trauma, right? So that when we work with people that have physical, emotional, witness, vicarious trauma, you're at work, seeing it happen, then you're coming home and getting another dose of it. And we do see that a lot. And, you know, and our trauma program helps, you know, help to look at that and tease it out.
Right. And this is for Dr. McCormick, when a healthcare professional is suspected of having a substance use disorder, can you just walk us through sort of what that next step process is, particularly with them operating with a state license?
Yes, it's a very common question that we get when we get those calls from family members or partners about their loved one or their work partner. You know, what's going to happen to his or her license. So the biggest thing that, you know, we all know is you have to ask for help. And if people ask for help and then get the help that's needed and get the adequate treatment, in the long run, it's going to be okay. Will some people have more bumps along the road and, you know, maybe some time out of work rather than others? Yes, certainly that may happen. I can't tell you 100% that everyone comes and gets adequate treatment and then is right back to work, but that's also dependent on a lot of what's happened on the lead up to someone getting here and whether there are legal repercussions or whether there has been diversion at work or whether there have been prescription writing that's, you know, come to the attention of the DEA or the Attorney General in that, you know, specific area. So they are all factors that we deal with. So we take care of this and walk through this with our patients all the time. Extremely common though that's a worry. So I think that if everything went according to plan, what we would love is that, number one, the patient, and may not fully, but at some sense has some surrender early on and asks for help, realizes that it is an issue, whether they're, you know, come here of their own accord or, as we always say, gently shoved into here by family or their support at home. Once they come here, we're able to take over and help them with that. So typically, if it's a physician, most of the states, really all but 2 in the United States, have terrific physicians' health programs. And so we help educate them on that. So while they're here with us, we like them to voluntarily, we don't report people. They call on their own and they enroll in one of these physicians' health programs. So there's a study that's been done, and everyone needs to hear this statistic because it's mind-blowing, that of the patients, over 303 physicians were studied that had adequate treatment. It's a 3-part head here. Adequate treatment on the front end, enrolled in a physician's health program, and then were active in 12-step recovery, have an 88 to 91% success rate at 5 years. Now, there was a small subset, about 15% of those patients that had what they called a slight slip or a slight relapse, but that was quickly figured out by being in a monitoring program. But that statistic is unbelievable. So if you tell anyone that, when we know that what the statistics are around the country for, you know, substance use, that's pretty mind-blowing. So if the point is we have to get those patients to come to that conclusion. And where they run into trouble, typically we see, is if someone comes here of their own accord, they have no legal trouble, no trouble at work, no prescription writing. They just say to us, well, hey, I just want to get adequate treatment and then go home, go back to my life. And what we help them to see is that when they renew their license, whether that's in a year or in 24 months or in 2 months, those questions typically are on the renewal of their licensure. So at some point, the board is going to figure it out, or the licensure board. So what we try to get them to do is get in this voluntary, completely voluntary, confidential programs, which are these physicians' health programs. The nursing associations also have very strong programs, and certainly most of the states in this area. And we also get our nurses enrolled, and then dentists, the same thing. Anyone that has a license, really, we help to fit them into what their monitoring program is. If someone does have legal trouble, though, we do help them with the advice of that. We can't give legal advice, but we help direct them and what they need to do. The bottom line from what we've seen from doing this for a while and from all of our personal experiences around this is that if someone has good recovery, we always say this, in good recovery, there's nothing you can't accomplish. And what that means is that, as we all know, once someone does get sober and gets into the recovery and gets home, life doesn't stop. Life keeps coming at them. And the point of that is that there may be some bumps, as I previously said, around licensure, around work. But we're able to help them to deal with that and help them be prepared for that and help them to move forward. I think that's the biggest thing. So coming into treatment as a physician, as a nurse, as a dentist, is not a death sentence by any stretch. It's the best thing that can ever happen to someone, because it allows them then to have advocacy starting with us, and then we hand it on to the next organization.
And Dr. McCormick, we had one question that popped up that's relevant to what you just talked about with that statistic. Was that relevant for just substance use or mental health as well?
Yeah, that was based off of substance use. Okay. What I would say, though, is at Caron, Mark, it goes hand in hand, as we all know. So I think we were in the low to mid 60s of co-occurring disorders when I started here 7 years ago or 8 years ago, whatever that is. Now I think we're in the mid 80s when they, the numbers crunchers look at it. But all I know is that when sitting with patients on a daily basis, it is much more common to see that, that people have co-occurring disorders. And so that study, unfortunately, yeah, the blueprint didn't parse that out. It was primarily based off of substance use, but the point is that we see it all the time. We had done just a quick study on another talk that I did yesterday. In 2000 and really, I guess it was 19 through 20, our Caron's amount of generalized anxiety disorder was around 15%. And in 20 through 21 now, we're up around 25%. So it may not seem like a significant number, but to us, that's that's 10 more people out of 100 that have anxiety, and that's probably driven by the COVID and by what's going on and by life and by all the worries. So,
right. Kathy, do you have anything to add to that?
No, just that I wanted to just maybe add on to what Dr. McCormick said. It's when we treat the patient, it's the whole patient, right? So that monitoring, the statistic is the monitoring is a variable of that. So they take a deep dive for a 6-week program into, after, being assessed by a multidisciplinary team for addiction primarily, but then mental health, family, all the things that you can think of that will, kind of be part and parcel of what they're going to need in early recovery to heal, right? So as they leave us and they're bolstered by what they had learned here, and they're willing to continue it, get a sober support system, and be monitored, all those things together, and then continuing care with a therapist, which I think we'll talk about in a little bit, but whatever their needs are from a continuing care standpoint, those all things will ride together. They'll ride together in the same kind of package to have sustainable recovery and life balance. So addiction doesn't live in a vacuum, right? So all these things kind of go with it, and the monitoring piece is a big part.
It is the
accountability.
Yeah, the physician's health programs and the nursing programs, nurses assistance programs, were enormous. I can't tell you enough what huge advocates we are for them. We love them. We're very supportive of them because we know that it helps keep people continuing in their recovery, continuing to grow, and keeps the public safe, really, because that's the people, and they do some of the best work around, really, because they're able to help physicians, nurses, dentists, whomever it is, once they return home. So it's just really they're wonderful programs.
And this next question is for all of you, but maybe we'll start with Steve to add his comments. The healthcare professionals program at Caron is considered a signature program, and they are treated separately from the, if you will, general population. And the same goes for Veritas's very specific patients that come into their program. Can each of you give reasoning behind why they are treated separately from general?
Well, well, thank you, Mark, for having me on as a panelist, and it's great to be here this morning. From our perspective, telehealth makes that possible. So, prior to COVID, telehealth was not really adopted in any meaningful way in the outpatient substance abuse treatment field. And what telehealth really allows us to do is to bring together a patient population of licensed medical professionals to receive treatment together. And so that's really that level of peer support, the programming that's very specific to the unique needs and issues related to licensed medical professionals, having trauma-informed programming. A lot of the doctors and nurses that we're seeing today are dealing with PTSD and exhaustion for what's going on right now with COVID being on the front lines. So this just was not, it's nearly impossible, would have been nearly impossible on an outpatient basis to be able to create an intensive outpatient program for licensed medical professionals exclusively. So with the adoption of this new technology and the data that's coming out continually to support this new technology, it really allows another opportunity for someone that may need a lower level of care, or someone from an aftercare perspective, to get high quality treatment with their peers, with curriculum specifically designed to address the unique needs of licensed medical professionals in a way that's never been offered before.
Kathy or Dr. McCormick?
Yeah. Sure.
Yeah, thanks, Steve. It's a great take, and it's so relevant. And we see that as we hand, and Kathy will talk about that, as we hand our patients off, once they leave us, the ability to be together. From a global aspect, Mark, Dr. Gable was kind of the pioneer who created this program here at Cairn, and it was his vision to put the healthcare professionals together. So we all know that the disease is the same, but the nuances are definitely there. And so the ability to sit, for an hour at night after dinner and just talk to, someone else who does a similar thing, similar life experience, to sit at lunch with them, sit at dinner, before COVID, ride out to outside meetings together. That experience is extremely valuable that we've seen, because it's questions from, what do you do when a coworker, I'm back on the floor and a coworker says, "Where have you been?" to a patient comes in and says, "Hey doc, where have you been?" Or, "Hey doc, can I ask you a question about my son?" And then boom, it leads into that, or licensure, or professional issues. So the healthcare professional patient is extremely difficult to treat. Let's all be honest. Everyone on this call knows we're extra special. Is the way we look at it.
Unique.
Yeah, unique, and we think we're unique, and it's extremely challenging. So to put those like-minded people together is a true chore, but it's the way it needs to be appropriately treated. And there's a seriousness to the treatment there, not that there isn't anywhere else, but there's just a different element, I would say, and it really, really works very well. Works very well for us here at Cairn, extremely well, and it's been a great program. So go ahead, Kathy. I'm sorry.
Yeah, good. No, of course, it's all good information. So I actually had the opportunity to see what this looks like as Dr. Gable conceptualized this idea, and it became his baby, and he's done such a great job with it and has included us in it. I saw the difference when it was the track. We called it the track. So the healthcare professionals would be, this is years ago, out, amongst the campus, in specific, units, whether it was gender specific or mostly that gender specific. And it wasn't productive, because a deeper bond occurs in the milieu when you have a cohort that has commonalities, right? And that they can talk about it. There's a certain amount of fundamental privacy and trust, like those questions that Dr. McCormick raised about, what do I say to my neighbor even? I'm a doctor in the, in the area, I'm a nurse, where have I been? It's so they get to talk about all these things and bring them to group. The other part of that is when they were out in the track before we got the standalone building 5 years ago, and you know, people would come to them, Doc, I got a pain, or, you know, like they would get involved, like they became this, this go-to person for things that then would detract them from their programming. And I saw this on a practical basis. So to have them in one place sharing with each other their concerns that are specific to them really creates a whole different experience. And I saw it, the contrast was really, really compelling. So, yeah.
And that leads us to a good segue into sort of what the different methodologies are most effective for treating this patient. I know that Steve had some good stats as far as telehealth and what you've seen.
Yeah, you know, it's been a fascinating and incredible time in the business of being in the outpatient treatment services. So we've been into COVID now for about a year. And from an outpatient perspective, out of necessity, the entire industry adopted some version of telehealth to deliver clinical services. In many cases, in-person was not an option, actually prohibited by the state in which you were licensed in. So we're a year into it right now. And what's fascinating is a lot of data is coming out right now in the form of white paper studies about the past year. There was an article in the Journal of Substance Abuse Treatment that was written by several medical directors of state physician health programs talking about their experience in response to COVID. And one of the things that they talked about is the unprecedented use of telehealth for evaluation, treatment, and monitoring of licensed medical professionals quite successfully and without an increase in relapse rates. So that's pretty, you know, because physician care has always been the kind of gold standard in treatment. Dr. McCormick talked about that stat on just how incredibly successful state physician health programs are when a physician is being monitored. So just anybody on the call listening in right now talking about, well, you know, the feedback coming in from these state PHPs is that telehealth was successfully adopted out of necessity, but will probably be around in a post-COVID world. You know, there was another interesting white paper study done by the Betty Ford Foundation that talked about comparisons of their virtual IOP compared to their in-person IOP program a year into COVID. And the data suggests the following. There were higher patient engagement, higher clinician satisfaction. Patients remained in the program longer than they would normal because the ease and convenience of it, and at about the same rates of sobriety. So, you know, that data is really interesting as well from a virtual outpatient perspective. And it's so interesting. The Mayo Clinic and even the Freedom Institute is coming out with something over the next month, just talking about patients being more inclined to be honest in a virtual platform versus an in-person setting, which I thought was pretty fascinating as well. So from our perspective, we're excited about the virtual intensive outpatient business. There are a lot of challenges that have yet to be resolved, you know, from a state jurisdiction perspective, from a insurance carrier reimbursement perspective. It's a fluid market. Right now, there's waivers in place because of, you know, emergency crisis waivers in place. All of that, this will kind of be figured out over time. But the first thing that came back is, does this work? And the data is suggesting that it produces good results. So the fact that you know telehealth allows you to have a greater reach and in theory offer a product at a reduced price because it's done virtually without brick and mortar, there's going to be, we believe it's going to be here in the future. And I think it allows a unique opportunity for a medical professional that either does not need a high level of care like residential treatment, or someone transitioning out of residential treatment to get clinical treatment with their peers. And as Dr. McCormick just talked about, it's so critically important when you're working with this demographic.
And Kathy and Dr. McCormick, what about on the inpatient side as far as
Yeah, go ahead, Kathy.
So as far as what we had a pretty big shift, I guess, about a year ago to switch over to things that we had to do more virtual. We were very, we interacted with families, and people were always coming on campus. So, and human beings are adaptable. Everybody adapted to it over time, and I think that we found a really, good way to integrate what we need to do virtually with what we always have done from an inpatient standpoint. At Caron, it's not a one-size-fits-all. When they come in, they're assessed by a multidisciplinary team, and medical, psychology, psychiatry, family, everything is assessed. And at that time, the team and the patient together, because we believe that this is extremely important, that they develop their own behavioral treatment plan. So none of that has really changed as far as how we deliver our services or how we assess people. Just in this virtual world, we have changed a few things that we've had to that aren't person-to-person contact for the obvious reasons. So for that reason, we actually know that as we go through this process with them, every person is, yes, addiction usually is the primary. There might be addiction interaction issues. There might be trauma. There might be complex trauma, PTSD, anxiety, depression. We tease all that out and then tailor a program to meet their needs, and then bridge that with continuing care. So all of that has remained the same for us, and we continue to do so on a patient by patient basis.
Yeah, no, thank you. I think that, when talking previously, the frontal lobe and the I've got it is difficult with our patients. So they say, well, I realize now I'm in treatment and I know I can't drink again, or I can't, use opiates again. But we have to really help them understand that that it's a whole heck of a lot more than just that. And some of the unique things that we do, which we love, is we have a 4th step group, which they're one or two patients would present, just one or two people on their 4th step, which is really unique, and it's a very interactive group that they respond very well to. The other one is our HOW group, which we do, which is honesty, open-mindedness, and willingness. That's Doctors Gable and Shioli and myself. And it allows them an hour and a half to really just share anything and everything in between. And we love that. And the honesty that we get out of that group is great. We always use our example of, we had a dental student years ago that was in the group with us and used to tell us we were all full of crap and this is all crazy and I'm having all these cravings. But, we loved it because we watched him grow and progress in his time with us, because he was able to get honest like that. So that's a huge group for us. Another interesting one, and I'll let Kathy talk a little more, is Enneagram, which we do with our healthcare professionals. Yeah. It's personality typing or categories, and the insight that our patients, because look, most if not all addicts or alcoholics are extremely smart people, or at least that's what we all claim. So, but they are. This patient population is smart, and boy, this challenges them. So I'll let you talk, Kathy, about that.
Yeah, please, and thank you for that, because that's one of my favorite things to do. I just actually left that group before coming in here, and it amazes me, like, the common language around this, and how people who are so left hemisphered and academic and scientists, right, that they actually really do a deep dive into this. And what it is it's personality, like Dr. McCormick said. Medical professionals sometimes have a thinking of, they're self-directed, they have thoughts about themselves, the uniqueness piece to it. So this gives them an opportunity to do, it's a self-discovery that they get to decide which type they are, what has impeded them in not being able to have sustainable recovery and life balance, and there's some principles attached to it. It has just been just a godsend for these people who, and I can go into the lounge right now and they would be probably talking about it. So it just is a really helpful, and what it is not just finding out what type you are and what impedes you, but then it's a 5-step principle process to be able to, leave here with a really good toolkit of coping strategies. I mean many, not just, that's just one thing, but that just is something that people really seem to kind of relate to, because they get to chart their own course. And it's been very helpful. Thank you.
Right. The last question to all of you, very important. You know, when people leave treatment, we know that a lot of times the real work begins. And how do we help keep healthcare professionals on track to succeed in their recovery?
I'll jump in. You know, we have found over the past year, we have integrated physician and healthcare coaching into our virtual intensive outpatient program. And we have found that to be really useful. You know, physicians in particular are so brilliant, but quite often lack basic life skills, self-care, managing finances, managing your practice, managing staff, and the integration of a high-end level of physician coaching into clinical treatment as medical professionals perhaps leave residential treatment and re-enter the workplace. Either they're being monitored by a state PHP, but that element of physician coaching or nurse coaching, these are physicians and nurses who are in long-term recovery themselves, just adds a component, someone to have like almost on your shoulder when you re-enter the workplace, dealing with some of the issues that are problematic, especially in today's day and age with all the challenges around with healthcare. So we have found that, and providing coaching for physicians in particular has always been challenging, right? A standard, let's say, recovery coach per se, as talented, as gifted as they may be, is always a difficult match. So finding a colleague that is sober, that can kind of has been through those similar experiences has been such a useful tool from that perspective. And then on the other end, you know, we talked here, you know, someone goes to Karen, they're going to have an incredible experience. Someone works through a state PHP, the numbers of success is staggering. The problem that we have, right, is every person in our program is a mandated client, someone who's been mandated to receive treatment by either a state physician health program or their employer. We currently don't have a single patient who is voluntarily seeking out treatment. So for us, the big picture is, well, you know, the small part of the population that actually goes through these channels does really well. But what about that whole other section of medical professionals out there who are suffering in silence? You know, the stigma of substance abuse and mental health in the medical community is so severe. And it's really, you know, suicide rates are up. Medical professionals are suffering in silence. And what I'm hoping for is that what COVID has done, as the entire medical community has experienced some form of trauma, that there's more compassion and empathy for those that are struggling. So we think a lot about, like, you know, how can we get someone to voluntarily begin the process of asking for help? And maybe because of those licensing questions, it's going to be hard for them to get into clinical treatment. We think maybe a less stigmatized solution may be coaching as a first step, where there's no issues around reporting, whether it's perceived or real, the consequences of doing it. But I mean, what, you know, collectively as a treatment field, there's this kind of part of the population that, you know, is struggling but refuses to ask for help. So we're constantly looking for ideas and solutions and ways to reach out to the community to start the process, a softer, less stigmatized solution, just to begin to ask for help.
Yeah, thanks, Steve. That's very, very true. So what we would say is, you know, from our standpoint at Karen, what we recommend is to get enrolled in a physician's health program or a nurse assistance program, or, you know, a nurse monitoring program. So does that mean that it's just about the urines or the blood tests or the hair tests and you're following toxicology? No, that's a very small portion of it. Now, that is a necessary portion of it, you know, is the actual toxicology and the monitoring. but we know this disease that even if you told someone you're going to test them, if the disease is active and you know, they're going to try to find ways around that. So the reason we love those programs is, number one, they're huge advocates for the physician or the nurse or dentist. I mean, they will, you know, they've gone to board meetings with people and testified with them, for them, and everything. But just they help them with when you apply for medical malpractice or re-credentialing of privileges or re-upping your license. You know, a stamp of approval from them is what allows our physicians to kind of decrease that chain that they have, because that's a big part of this, because they realize there's a lot of other healthcare professionals that are in the same boat as them, and it's the percentages nationally, as we all know, are a little higher than the national average because of probably the stress environment and exposure. But the physicians' health programs and the nurses' assistance programs do so much more. So very frequently, similar to what Steve said, you know, you get plugged into one of, you know, Steve's program with group therapy. There's individual therapy. There's check-ins, which are so valuable. It sounds like, oh, I have to talk to them, you know, this month for 3 to 5 minutes. Well, yeah, you know what? It's actually another contact point for you. You know, many of the physicians' health programs have worksite monitors and they have PHP monitors. So what does that mean? Well, a PHP monitor is someone else in recovery who's in the PHP, who you may see at your caduceus meeting or your, you know, AA meeting, or you may see at work, and you meet with them quarterly, multiple times or once, and touch base. So worksite monitor is just someone else that's an advocate for you, that says, yeah, you know what, he or she showed up to work every day. They're on time. They don't look disheveled. I mean, these are simple things, but these are all, it sounds like a lot, and that's difficult for us with some of our patients. They're like, oh my gosh, this is my whole life. Well, yeah, your life changed in a good way, though. So now we're not thinking about getting that next drink or that drug, or, you know, sneaking, conniving, running around and doing this at night and during the day and all that craziness. Now our life has changed. It's a whole mindset, and it's all about recovery, and everyone's able to fit all of these activities into their daily lives. You know, we're also extremely big proponents of 12-step recovery. You know, certainly AA and NA, I think have worked for so many people through the years and are wonderful programs and life-changing. And so we introduce them to those programs. You know, we have recently, over the last few years here at Karen, look, Karen's been around 65 years. It's not an advertisement, but Big Karen was, you know, with Bill Wilson and Dr. Bob way back at the beginning. So we go, you know, we're pretty deep here from AA, but we've started the open-mindedness that all of us have to have has been great here, in the sense that now we offer patients Dharma recovery, or called refuge recovery, which is more of a Buddha base. So they get an introduction to that. They have to be in, you know, to be in a program. We've even had smart recovery introduced in here at times. We have a few people that have some experience with that. So we try to meet the patients where they are, but their lives completely change when they leave, and it's all for the better. That's not a scary thing. Sure, all of us hate change, but it's better, and it's a daily thing that we all need in order to continue to be sober. So that's really what we see once our patients leave us. You know, as Steve's talking about the outpatient and the telehealth exposure, it's an interesting take, and he's right that, like, hey, if I'm running from the hospital and I know I have group at 6:15 and it's now 10 of 6, and it's a half hour to get there, maybe I won't go. Maybe that's the old mindset, you know, and I'll text the guy that I can't get there. Now all of a sudden I can jump on my phone. Yeah, maybe for the first 10 minutes I'll be in my car, but then I'll be in my house and I'll be able to do my session. So that, in a positive way, that's what we've seen, and that's what we've heard back from our professionals.
And just to jump in there, Dr. McCormick, there was a question concerning that. By PHP monitors, do you mean connecting participants with each other, or do you mean the agreement monitor?
What we mean is enrolling formally with a physician's health program. You know, I know we're probably talking to people from all over the country, but certainly in New York it's CPH. In New Jersey it's the PAP, and Dr. Baxter. In Pennsylvania it's the physician's health program. Washington DC is a terrific one. You know, Virginia, great one. Maryland as well. It's MedChi. You know, it's a formal agreement. So they sign a formal contract with them, which is typically 5 years, And there are requirements on there. Yeah, the first few years, is it more demanding, or, I don't know, is it more regimented? Yes, it absolutely is. And then as you continue to show that you're progressing in your recovery, it does become a little bit less taxing for you as you go through it. But, I'll tell you the truth, Mark, we've seen many physicians that just re-up when their 5 years is done. Because why change anything? Like you hear in an AA meeting, why would I change anything? Because it's working for me now. And so we see that over and over again, because these are wonderful organizations. We at Caron are extremely passionate about this. I think you all can feel it through the call today. Like we love it. But yeah, do Kathy and I worry at night and think about patients that left 6 weeks ago and 6 months ago? And when we hear back from them, we love it. So our ability to hand it over to these organizations, these physicians' health programs, is great, because we're such huge advocates. We love them. And to hand to a program like Steve has is wonderful, because we know they're getting continued great care, the attention that they need. And this is not an advertisement for anybody. This is just the truth, because this is serious stuff, as everyone on this call knows. Like, yeah, your license, this isn't just willy-nilly. Your license is, if you continue to have problems, yeah, then there are going to be legal and licensure repercussions. Absolutely.
Right. One of our participants has in their workplace a self-referral safe haven program, but cites that due to stigma, there are many doctors and nurses who are hesitant about coming forward. How do we deal with that and stigma around this?
Yeah, I think that Mark, we can't ignore that. There still is a stigma. We think it's decreasing, but it's the same as I think that Steve had mentioned it, or maybe you, Mark, it with mental health, with an awareness and an understanding across the country that it's getting better and better. But yeah, we still have work to do. What I would tell those, healthcare professionals is that if you stay underground, it's not going to turn out very well. Then all of a sudden, everybody knows it. When something happens and someone was seen in the OR at night and doing this or that, or in the emergency room, all of a sudden there's drugs missing from the Pyxis, then the gig is up, and then it's a lot. It just ends up, and it's not a threat. It's just what we see. I don't know how we can raise that stigma other than education, as we all know, and how important recovery is. But I'll tell you that we do have talks with patients many times if they're going on job interviews or they're losing a job and they're looking at another one. If you don't feel that the place you're going is recovery friendly, because unfortunately not everyone is. We just had a patient who left to go back to New York City, and he didn't feel totally comfortable in his hospital. So we talked to him about, hey, maybe shifting on, professionally.
Right. Kathy or Steve, anything to add on stigma?
I think everyone comes into their treatment experience at a different level, right? Some people are just coming in right off of a run, and that would be, that they're still using their drug extensively and come in. And then we have people that have come in that have gotten maybe in trouble and they've stopped. So I think that we need to look at where we come in and talk to them about the monitoring program. Is we assess them as soon as they're ready and can receive this information and understand it, then we talk to them about it to try to reduce the stigma. We also have a very viable community of people that we do continuing care with in our area that are willing to talk, doctors that are willing to talk here. They're in Pittsburgh, they're everywhere, that can help actually maybe minimize and reduce that anxiety around the stigma, because these are guys that have been doing this for 5 years. They're re-upping their monitoring program. They're strong in their recovery and they're thriving. And that sometimes helps kind of quell that, that anxiety around it.
I would add that it's a very serious issue, and not just specific to medical professionals. I think as a society, the words we use are really important when we talk about substance abuse. And so I think that's critically important. It's interesting, I was in downtown New York after 9/11, and New York, the months after 9/11, there was this real kind of trauma bond with New Yorkers where we had a shared traumatic experience where it really didn't matter what race or nationality you were. And what I'm hoping to see in the medical community in a post-COVID world is that empathy and connection where people are more open and willing, feel less judged to talk about maybe it's okay not to be okay. And I'm not just talking about substance abuse, but just mental health. And the more that we can normalize the conversation around mental health, I think it's critically important. I'm a recovering drug addict. I'm a recovering cocaine addict. And I share that with you because the more that we can normalize this, having physicians or nurses in recovery talking about their journey with substance abuse and their recovery and how their lives have unfolded and blossomed are so critically important to create hope. So it's a process. It's a slow process, but I'm so hoping and actually praying in a post-COVID world, the medical community comes together on this issue.
Great. I am going to go to some of the questions in our Q&A now. John said he is a retired attorney who was trained at Hazleton and was involved in the lawyers program there. He saw major barriers in the group where shop talk, ego reduction, and acquisition of some degree of humility. How do you deal with the issue of, as he says, specialness amongst the population?
Yeah, humility is a big one. Go ahead, Kathy.
Well, I think it's like almost like the honesty thing, right? So it's like this progressive piece. It takes coming in, being a positive peer community of people who want to get well. Like you've got this one person that's coming in and maybe people have been here longer and there's no humility, there's no surrender. And truth be told, we've got one or two of them right now that, has to be able to, other people are going to model a different way for them. We're going to continue through the HOW group and Enneagram work and individual and groups to hold the mirror up to these people to see it. So it's not just like a real fast answer. It's over time, them being exposed to people who want to surrender and have accepted their condition, their insidious condition, and that they want to get well. So I think that over time they can progressively see that. We see people come in here yelling at us, cursing at, like they're mad. And then when they leave here, they're holding on to the door, the post saying, I don't want to go. So it's a beautiful thing to watch, but I think it's over time, it's progressive relative to that humility surrender piece. I don't know, Dr. McCormick, what do you think?
Yeah, that's right on. And it's everyone's at a different stage when they get here. And that's a fair and a great question. And I can understand that from the surface that our program or what we have here is not that where, they're treated with kid gloves. It's far from it.
Right.
And it's a lot. It's, part of it's our secret sauce here at Cairn, but it's pretty intense. And there are a lot of meetings. There's a lot of people involved in our team, professionals, and many of us have our own recovery. And so we know, and it lends to kind of knowing really where they are and confronting them in a gentle but in a loving way, because really it is all about that love. But everyone's different. It's a great question. All I would say is it's always on our radar and it's cyclical. Kathy's right. We have a couple patients right now having a difficult time, but that's just what we expect. And the amazing thing that we've been so lucky and is that a lot of times the community is able to help each other. And when we hear the community sharing with them and confronting them, similar to probably what Steve sees as an outpatient, the patients do listen to each other. So like, hey, when people are calling them out on this, that, or the other, the effect is extremely strong. So we try to kind of cultivate that environment here at Cairn. So yeah, great question though.
It is.
Mark, I would add, it was funny what we were just sharing. I just recalled when I was in treatment back in 2008, there was a clinician that, was so tough on me. And, I had this just massive ego and I was so suffering on the inside. And when I left treatment, I'm like, oh my goodness, I can't stand this person. I look back now and saying that was an incredible clinician. And that was exactly what I needed in that moment in time. And so, I think there are some just wonderful clinicians. And what we're finding also with the spaces, not all treatments the same, but not all clinicians are the same as well. It takes a certain type of clinician that has significant experience working with medical professionals around substance abuse and mental health that works really well.
Great.
Very true.
One more question coming in here. What resources do we find helpful for people to determine Enneagram type?
Oh, good question. Okay, so you can actually order them on Amazon.
Ah,
I just did the group, so here it is. The Wisdom of the Enneagram is one, but the one that you can really actually start off with, I think this is the basic one, is the Essential Enneagram, and it'll help you determine your type. It's fascinating. I recommend it for everybody, wherever you're at in life. It's a skill when learned that you will use forever. So Amazon has them.
great. Last question that we have time for. Have we seen a need to change treatment modalities during COVID, more trauma focused, and what do we do to focus on burnout at work?
Well,
Yeah, I think
I'll take the trauma question.
Yep.
So I don't think that we have changed we have phase 1, phase 2 trauma. They have remained the same. What we have to look at is when a person comes in, where again, everybody's treatment experience, they come into their treatment experience at a different level. Their primary substance abuse issue, is it going to be able to kind of calm down enough for them to be able to do the work, right? So we have to be able to see where they're at with that. Maybe COVID has intensified some of that. I'm not really sure about that part, but we have to really assess, are they ready to do the work? And if they're not ready, then we can bridge them to continuing care afterwards that's appropriate. But we're always assessing these people. So during COVID, as far as trauma, it really hasn't changed, unless maybe just the fact that they come in more traumatized, and we have to really assess each one individually. There was another part to that question. I'm not sure I forget what that was.
Burnout at work, but I think you answered.
Okay.
Yeah, very common.
Yeah.
Very common. Well, these people don't stop. So it's extremely common.
Right, right. Well, as they say, a good meeting starts on time and ends on time. So Steve, Kathy, Dr. McCormick, thank you very much. And thank you to our 96 participants who joined us today. As a reminder, today's presentation is eligible for 1 social work credit. So please keep your Zoom session opened so that you can do the evaluation, and then you will receive your certificate via email in about 2 weeks. Karen Treatment Centers is also pleased to provide some additional continuing education opportunities for professionals. Next Monday, Karen, Florida, will host a panel discussion titled Women's Wellness, How to Be Gender Responsive and Recognize the Female Impact on the Family System. We will also host a webinar next Wednesday entitled The Importance of Secure Attachment to Long-Term Sobriety. Both of these presentations are eligible for 1 social work credit. You can go to karen.org/webinars. And you can also always reach out to your local regional resource director at Karen. So thank you again to the panel. Thank you again to all of our participants. We appreciate your time, and I hope everybody has a wonderful day.
Thank you.
Thanks, Mark.
Thanks all.